This is the presentation on pain management. The ANA position statement on pain management is that the nurse has an ethical responsibility to relieve pain and the suffering. Nurses should provide individualized interventions. The nursing process should be used to guide the nurse's actions. Multimodal and interprofessional approaches are necessary. Pain management modalities should be informed by evidence. Nurses must advocate for the policies, and nursing leadership is necessary for society to appropriately address the opioid epidemic. And our statement here at Jackson is that we, along with the other members of the patient care team, must work to provide the best pain management possible. Unrelieved pain can have many harmful effects on the body. Some of them are listed here, such as increased heart rate, oxygen demand, hypercoagulation leading to a deep vein thrombosis or pulmonary emboli, delayed gastric emptying and reduced bowel motility, decreased immune response, which can lead to an infection, decreased lung expansion, which can lead to atelectasis, pneumonia, some genitourinary issues, such as increase in hormones and enzymes, which can lead to urinary retention, fluid overload, anxiety and decreased quality of life, and lack of sleep. When pain is adequately controlled, it has been shown to decrease the risk of postoperative complications, promote quicker recovery, decrease the hospital length of stay, and increase patient satisfaction. We begin with the assessment of pain. Here are a couple of quotes on this slide from the Joint Commission website. All patients have the right to the assessment of pain, and precise and systematic pain management and assessment is required to make the correct diagnosis and determine the most efficacious treatment plan for patients presenting with pain. When to perform a comprehensive pain assessment? When a patient is admitted or transferred to your unit would be a good time to perform a comprehensive assessment. Any event that may be causing pain or may lead to pain is a time to perform an assessment. When information is limited, such as the patient can't give you information or you didn't get a lot of information about the patient in report. When the patient is new to the nurse, such as during shift report, is a good time to do a comprehensive assessment. And before intervention, such as before pain medicine is given, before a dressing change is performed, things like that. Here is where your pain assessment tool is found in Paragon. We go to the Pain Assessment tab, right here, and for every patient receiving an opioid medication, the sedation scale here needs to be addressed. Here are a couple of pain scales down bottom here. The one on the left is for the advanced dementia patient, to answer those questions to see about their pain management. And on the right is the behavioral pain scale for patients who are nonverbal. But for the comprehensive pain assessment scale, we're going to go to the pain assessment right here. When we click on this pain assessment tab here, this box is going to open up right here. And so we're going to document a new comprehensive pain assessment. We're going to click on New right down here. Now this box has popped up. So there's lots of information we can put here. You put the location of the pain, it's a drop-down menu. The numeric scale or whichever scale you're going to use, that's also a drop-down menu, and then you put your pain score right here. And just fill in all of this information. Down here we have the pain character, what type of pain it is. We have the pain distribution, does it go deep, does it radiate somewhere else. We have the pain duration, is this acute or chronic. We have the pain goal here. We'll address that here in just a minute. Is the pain intensified by anything in particular? And what type of pain management we have performed. These are the non-pharmacological pain management that we have done. So we'll address that again in a minute as well. And so you can just read what all is involved here, and you just answer everything that is appropriate and click OK. The pain assessment goal is one of the items on the comprehensive pain assessment. And so I just took that little part out of the assessment to put it on this slide. But the goal is not going to be the same for everyone. So we're going to base our goal on the patient's functional status, their pain history, and whatever goal is agreed upon by the patient and or their family, because this is their goal, not ours. So a realistic goal for most patients is usually 3 or 4 on a scale of 0 to 10. We should also offer some non-pharmacological pain management as appropriate. And here's a quote here. They may serve as a complementary approach for pain management and potentially reduce the need for opioid medications in some circumstances, ensuring that pain preferences are discussed and, at a minimum, providing some pharmacological treatment options. Here are some examples of some non-pharmacological pain control methods that could be used as appropriate. You can use diversion techniques, therapeutic communication, breathing exercises, heat or cold when ordered and as appropriate, therapeutic massage, again as appropriate, relaxation techniques, repositioning, visitation with people, things like that. And then on the right side of your screen here is the non-pharmacological part of the comprehensive pain assessment. It's listed under pain management. And so you just click whichever methods have already been done, or click other and you can add in your own. It's important to monitor the patient closely for possible side effects when giving opioid medications. Some common side effects include sedation, respiratory depression, constipation, nausea and vomiting, itching, hypotension, and confusion. Now, sedation and respiratory depression are of course, the most serious side effects, so those need to be monitored frequently. Does the patient need to be awake? Well, that depends on their status. One trick the nurse can use is go into the room and check out the equipment. Check the IV equipment, check out other equipment to see if they're working. Often when somebody's in the room, the patient will stir a little bit. If the patient stirs a little bit, then you usually don't need to do any action. If the patient does not stir, seems to be very still, very quiet, and then you might need to arouse the patient just to do a quick assessment to make sure that everything is okay. Side effects from opioid medication usually occur within the first 2 hours of the first dose, and they usually subside after 1 or 2 days after taking the dose, except for constipation, of course. That's not noticeable right away, and then it may take longer to get rid of. So the sedation level needs to be assessed within 60 minutes of giving the opioid analgesic, and that's on the pain assessment that we looked at earlier. Side effects may be prevented by properly titrating the dosages. So if 2 to 4 milligrams of morphine is ordered and they've never taken morphine before, I might try the 2 milligrams first. First of all, to see if that takes care of their pain, but also they may not have as severe side effects if I use a smaller dose. And reducing the dose of the medication is appropriate if the side effects are mild and if the pain is being well controlled. Some patients are more at risk for oversedation or respiratory depression. This might be the patient with obstructive sleep apnea, the very young, the very old patients, the very sick patients, opioid naive patients, especially naive patients who are receiving continuous opioid therapy. Also giving opioids with other medications that can cause respiratory depression. Obesity, decreased level of consciousness. So these are the patients who might be more at risk. They may need to be monitored a little closer. Sedation precedes respiratory depression when the respiratory depression is caused by an opioid medication. So it's important to do the sedation scale. It is listed here on your screen. It is also on the pain tab in Paragon. Also watch for shallow respirations or periods of apnea, respiratory rate of 10 or less. Assess the respiratory rate and the quality of the respirations. Don't depend solely on the pulse oximetry. Also do that physical assessment. Sedation may be necessary to adequately manage the signs and symptoms in the end-of-life dying patient. So it's important to remember the difference. If they're end of life, then sedation may be okay. We're looking a little more at that sedation scale. It's listed on this screen, but it's also on the pain tab in Paragon. If the sedation level is 0 to 2, 0 meaning normal sleep, 1 the patient is awake and alert, 2 the patient is slightly drowsy but easily aroused. These are acceptable readings and no action is usually necessary for these. If you click a 3, the patient is frequently drowsy but they are arousable. You might need to stimulate the patient, you might need to notify the physician, or you may need to call an ICE depending on what the situation is. If the sedation scale is a 4, they're somnolent, minimal or no response. Definitely call an ICE team for this one. Looking at some opioid medications. The medications may be ordered PRN or they may be ordered scheduled for someone who has pain management issues, or they may have something very serious going on, or they may be end of life that may be scheduled or something like that. So you may have PRN medications or you may have the opioids that are scheduled. Typically, opioids are going to be ordered PO or IV. IM analgesics are no longer recommended because the absorption rate can be unreliable, and that may increase the risk for sedation and respiratory depression. Plus, they can cause tissue damage. So typically, it's going to be your PO medication such as a hydrocodone or oxycodone, or it may be IV medication such as morphine or Dilaudid. Sometimes opioid medications can be titrated, such as the physician may order a PO analgesic 1 to 2 tabs, Q4 hours PRN, or for an IV medication they could order morphine 2 to 4 milligrams IV PRN Q3 hours for pain. So which medication dosage should you give? Well, we can base it on, first of all, the pain assessment. How severe is their pain? What type of pain is it? How long have they been having the pain? And that may determine whether you give the lower dose or the higher dose. Also, consider factors such as the patient's age. The very young or the very old may not need a higher dose. Their previous responses to analgesics, did the lower dose work previously? If not, then maybe you can use the higher dose this time. And their sedation level. If they're pretty sedated, you do not want to give a high dose of pain medications. Also consider comorbidities such as chronic pain. Chronic pain, they tend to have a higher tolerance. So just consider those things as well when you're deciding which dose of medication to give. The use of PRN range opioid analgesic orders is a common practice in the management of pain, designed to provide flexibility in dosing to meet an individual's unique needs. Range orders enable necessary adjustments in doses based on individual response to treatment. So, when you have a PRN range orders, the RN's responsibilities include knowledge of the medication, the onset, the time of peak, the duration of action, adverse effects, things like that. Verification of appropriate dose and the dosing interval for the current situation. Verifying of the allergy status of the patient. Are they allergic to anything that is in that medication? Informing the patient of the name of the analgesic and the dose to be administered, and evaluation with documentation of the patient response to the analgesic dose and interval. I encourage you to look up the pharmacy policy on range orders. It is listed on the screen here. If 2 doses are given, such as morphine 2 to 4 milligrams as mentioned earlier, if this is the first dose and I don't know how they're going to do with it, I may give the lesser dose. I may give the 2 milligrams, see if that relieves their pain, see if they have any side effects from it. If it does not control their pain, then I might give the remainder of the dose, and the next time I may give the larger dose. If the physician orders Q 4 to 6 hours PRN, then you can use the Q4 hours as your time frame. The next few slides are kind of a guideline to help you determine which dose of the medication to give. If the patient is having mild pain, nausea, agitation, or other symptoms, you might want to administer the lowest drug that is ordered, unless the previous dose did not control their pain, then you might want to go with an increased dose. Also, the hemodynamic and or the sedation status of the patient may indicate if the medication should be held. If the patient is having moderate pain, nausea, agitation, or other symptoms, you might want to administer the middle dose of the drug that is ordered if there is a middle dose. Again, you want to check their previous response to the medication to see if you need to increase the dose or decrease the dose, and check the hemodynamic and or sedation status of the patient also to see if the drug needs to be held. If the patient is having severe pain, nausea, agitation, or other symptoms, the nurse might need to administer the highest dose of the drug that is ordered. Again, check the patient's previous responses to the medication, and again check the hemodynamic and or sedation status of the patient. Sometimes a patient will have PRN medications ordered PO and IV. So if that is the case, then the nurse needs to use their judgment to decide which PRN pain medication to give the patient. If the patient cannot take in anything by mouth, then of course give the IV PRN medication. If the patient is able to take orals without any complications, then the nurse should give oral PRN medication unless the medication is only available in IV form, because a patient can go home on PO PRN medications, and that is a good trial to make sure they're not going to have any side effects and that it will control their pain. So use PO if at all possible. Of course, the nurse always needs to determine the patient's clinical status to determine which medication is best for them at that time. Combination pain management regimen is the recommended pain management practice. The universal goal is to provide balanced analgesia, and that means that you may use several different types of therapies to help the pain management. You can use non-opioids if appropriate, such as Tylenol or ibuprofen. Then there are opioid analgesics for the more severe pain or as appropriate. Sometimes a regional block is appropriate for the patient, especially preoperative if they're going to have a hip replacement or a knee replacement, or certain things will require a regional nerve block. Also, non-pharmacological therapies will be included in here as well. So sometimes using several different therapies will help manage a patient's pain. An important part of pain management is the pain reassessments. Here's a quote: "Reassessment should be completed in a timely manner to determine if the intervention is working or if the patient is experiencing adverse effects." So reassessment of pain is ongoing. Anytime you talk to the patient, you're assessing for their pain. It may not even be a verbal assessment. It may be what you're noticing in the patient. So reassessment is ongoing. And documentation of pain assessment and reassessment is done per the unit requirements. Pain assessment is often done on temp roundings. That is part of temp roundings. There are some procedural treatments that can help with pain management, especially for chronic type pain. Patients can have outpatient epidurals or nerve blocks for chronic pain, especially for like chronic back pain. L&D patients can receive an epidural block or epidural bolus. Preoperatively, some patients will receive a regional block, such as hip replacements, knee replacements, things like that. Also, acupuncture or acupressure might be an option for pain management. Some patients may receive a PCA, which is a patient-controlled analgesia, or a PCEA, which is a patient-controlled epidural analgesia, or a continuous opioid infusion for pain management. And so those are the ones that we're going to talk about next. Whether a patient receives a PCA, a PCEA, or a continuous infusion, those are managed by anesthesia services. So you need to call them if the patient is having any issues, such as if it's not controlling their pain, or if they appear to be over-sedated, or if their oxygen saturation is persistently less than 92%, or if the interventions that have been given for side effects have been ineffective. Those are indications to call anesthesia services. And when they are being contacted, contact them through the operator. Don't leave a message on the call room or the phone system. You need to get in touch with them directly. If a patient is ordered a PCA, there will be an order set. So follow the order set. It will tell you which medication to give, whether it's morphine or Dilaudid or Demerol. Typically it's morphine or Dilaudid. It'll tell you the dose, how often they can have it, how the settings to set in the PCA machine. It'll tell you typically when to call anesthesia, some medications that can be given PRN for side effects as well. For a patient to be ordered a PCA, they must be able to physically and cognitively use the PCA equipment. They need to be able to physically hold the button and be able to push the button. They need to understand that when I push this button, it's going to give me pain medication. And they need to understand that that's going to mean that I'm going to have a decreased level of pain. And they also need to have a continuously flowing IV with the PCA. For a PCA, the nurse giving the PCA must be an unrestricted RN, which means that they must be able to give opioid medications. They'll need to retrieve the pump from central distribution, remove the cassette and the key from the medication dispensing system. They need to verify the programming in the PCA with another nurse or pharmacy. They need to initiate the therapy, complete the documentation, which we'll look at that in a minute, and provide the patient and family education on how the PCA works and what the goal is with the PCA. Here are some things that the LPN2 may do regarding a PCA patient, if that is their patient. They can verify the correct programming because it must be witnessed. They can perform a focused reassessment. They can document their assessments as normal. They may discontinue the PCA. They can witness a discontinuation with someone else as well. And they may place the PCA on hold for oversedation, for example. Here are the assessments that are required with a patient with a PCA. Upon initiation of the therapy, a second nurse or pharmacist must verify independently that the PCA pump is programmed correctly and that the medication is correct and all that. They need to assess the infusion pump program, rates and intervals and dosages and medication. All that needs to be assessed at least once a shift. The patient's respiratory status, level of sedation, and pain control needs to be assessed. And any time an additional bolus is given, a reassessment needs to occur as well. Here is the documentation that is required for a PCA. This is on the PCA tab in Paragon. So you're going to fill all this out, the initiation time, and just fill it out, whatever applies to the patient. You're going to document the initiation and subsequent medication cassettes, the ongoing assessments, rate or medication changes when they are ordered, end of shift PCA counts need to be documented there, when it is placed on hold and when it is resumed, there's a place for that, and any boluses that are given. So just make sure this is filled out completely when a patient is on a PCA. A PCA setup is good for 48 hours. The goal being that a patient has been downgraded to moderate pain or mild pain from the severe pain, so the PCA may not be needed anymore, and hopefully they can start on their PO, PRN medications as soon as possible. If the PCA is to continue for more than 48 hours, then after 48 hours the cassette needs to be replaced with a new cassette. When the PCA is discontinued, there may be some medication that is left in the cassette. So 2 witnesses are required to waste the extra medication that is left over. So both parties who are going to witness should use the report feature on the PCA to determine what should be the remaining volume of the medication. Then the remaining volume is aspirated from the cassette and disposed down the drain and documented. I encourage you to look up the nursing guidelines regarding PCAs as well, and they are listed here on this screen. Another type of PCA is the PCEA, which is the patient-controlled epidural analgesia. So this would be fentanyl with a local anesthetic such as bupivacaine or ropivacaine. Or there may be an intrathecal or epidural morphine, which is Duramorph, and that is a bolus dose that lasts 12 to 24 hours. For the PCEA, the patient requirements are still the same. They need to be physically and cognitively able to do it, and the nurse requirements are the same as well. Notify anesthesia for any problems and things like that. Also, the nurse must assess for motor function using the Bromage scale, which is found in your Paragon documentation. So you will give them a grade of 1, 2, 3, or 4 based on this scale here. If the catheter becomes dislodged or is exposed, just cover it up with a sterile 4x4 and notify anesthesia. Here is a list of things to notify anesthesia for a patient with a PCEA. These are a little more specific to the PCEA rather than the PCA. So a sedation level of 2 or more, shallow respirations, periods of apnea, respiratory rate of 10 or less, the Bromage scale of 3 or more, depressed respirations, periods of apnea, I already mentioned that, loose wet dressing, motor sensory deficit, catheter displacement, signs of a hematoma or infection, or if the patient becomes confused, disoriented, or otherwise unable to manage their pain using the demand dose button. With the PCEA, the anesthesia initiates the therapy. They change the dose. They manage the dislodged catheters, disconnected catheter, wet dressing, signs of infection, and hematoma. So just to kind of let you know what their responsibilities are in this. Some patients may be on a continuous opioid infusion. This may be the palliative care patient to use for comfort care. This could be a critical care patient who is ventilated. For these, the pain and the respiratory rate needs to be assessed every 4 hours, and PRN once the symptoms are controlled, or more frequently if ordered or necessary. Opioid infusions are hung inside a clear plastic lockbox attached to the IV pole. An end-of-life or dying patient with a DNR status may require sedation to effectively manage their symptoms during the dying process. Therefore, it may not be necessary to reverse sedation in those patients. There are some special concerns with opioid management. Here's a quote. Many patients have complex pain management needs, including the opioid-addicted patient undergoing major surgery, or the patient who is at high risk for adverse events, such as a sleep apnea patient, and who requires treatment with opioids, or a patient whose pain management needs exceed the expertise of the patient's attending licensed independent practitioner. This slide is about dependence and tolerance with opioid management. Physical dependence develops with long-term use of a narcotic. It's characterized by the occurrence of withdrawal symptoms when the medication is suddenly stopped. Now, withdrawal symptoms can be controlled by the gradual withdrawal of the medication. Sometimes the withdrawal symptoms aren't quite as bad if they are gradually withdrawn. Tolerance is where the same dose of an opioid is no longer controlling the pain adequately, and an increase in dosage is required to control the pain. So this is where someone is used to taking the medication. Now all of a sudden morphine 2 isn't working anymore. They need morphine 4 now. So they've built up a tolerance. They're used to taking the medication. They're going to need an increase in dose. And so there's two types of tolerance. One is with chronic use, somebody that has chronic pain management issues or back pain or something like that, and so they're just used to taking the medication, or age-related brain receptor changes. So when you, at a certain age, sometimes you need a different dose of the medication. Here is a quote about addiction. Addiction is psychological dependence characterized by compulsive drug use and continued craving for opioids for effects other than pain relief. Opioid analgesics, benzodiazepines, and other sedatives and tranquilizers and stimulants have important medical uses, but they also stimulate the reward center of the brain. In susceptible individuals, this can lead to misuse, substance use disorders and addiction, and other serious consequences. Research shows that only 1% of patients taking opioids to manage pain for 3 to 6 months develop true addiction, and that pain decreases or resolves, so does the use of opioids. So that's something that can be mentioned to the patients when they're worried that they're going to become addicted. Most of the time, that does not happen, especially in a medical facility under controlled circumstances. They're not likely to become addicted, but I know some patients do worry about that, so this is some research that can be given to them. It is very important to document education with the pain management, and education can be documented in a few different places in Paragon. It can be documented on the pain tab in Paragon. It can also be documented in the education tab in Paragon. And so we need to document because the importance of documenting with the healthcare team about their pain in response to treatment. We need to document their pain scoring scales and assessment tools. We need to document the development of a realistic comfort goal, treatment options, what the drug is, the purpose for receiving the drug, potential side effects is important to document, and it's important to document that only the patient depresses the delivery button for the PCAs. And that is the end of this presentation on pain management. I hope that it has been helpful.